Okay, well, welcome, and I'm very excited to, welcome particularly our guest from Vietnam to this session. It's great to have colleagues from Hanoi here, and also to be able to have other colleagues from UCL and also our Global Business School for Health colleagues. So I think this is a great opportunity for us to think about how we can collaborate, share ideas and insights. I particularly want to thank Honorable Lee Van Kam. Thank you so much. And thank you for joining us and bringing this delegation and group. Of course, Dr. Fung, who's very much a pleasure to have here as well and to join us. And Dr. Mi Han as well. So I also want to recognize Dr. Stephen Roberts, who's here, and also, of course, Dr. Virginia Murray. So thank you to all of our panelists and of course, for my colleague in the Global Business School for Health, Yushi. Thank you so much. And then also Kabir, who will be moderating this session this afternoon. So it's fantastic, and I am very interested in the topic. I think it's such an important topic. It's not just in Vietnam. I think that the idea of misinformation and the impact that it has, and we all, of course, saw that during COVID, particularly here in the UK. So I think it's something that is very relatable. But it's great to see it being addressed. So without further ado, I'm going to turn it over to Kabir, who's going to be moderating this session, and I look forward to enjoying it and engaging in the Q&A as well. Thank you.
So welcome, colleagues, and I see a number of people have joined online as well, so big welcome to them as well. Am I audible at the back? So I just wanted to start by giving a little bit of a context to the series of talks that this is a part of. It's the third in our sequence of talks on transforming health systems. Previously, we've had talks on health workforce heterogeneity and urbanization and primary healthcare systems. And this is an excellent third edition on health-related misinformation and disinformation. The theme of the talks is transforming health systems, and we want to start a series of conversations that cut across sectoral and disciplinary lines. And rather than being academics talks, they should be talks that actually help us think about how we can bring about change in real-world systems. And that's why we have such an mixed, not only an eminent, but also a mixed group of panelists today. We really want to work with policymakers, we want to work with knowledge brokers, we want to work with academicians, and make some of these conversations happen that actually talk about change in real world. So without further ado, a little bit more about the actual topic that's been put together by the organizers. What we know about health-related misinformation and disinformation is that it is not exclusively a digital phenomenon. It's also a real-world physical environment phenomenon. And it's not only associated with specific communicable diseases, but with a very wide range of health-related issues. Non-communicable diseases in particular are strongly influenced by health-related misinformation and disinformation, and that's tended to be somewhat neglected in the policy sphere. So we expect to have an emphasis on that part of the discussion today. It sits at the intersection of information, social, and commercial determinants of health. There is also, I think it's important to recognize that it's not just an accident that misinformation happens. It's often engineered for very specific ends, not all of which are very good for society and do not have the best intentions. So it's worth thinking about some of the upstream determinants as well of misinformation. In response to this widespread phenomenon, WHO has called for campaigns to manage infodemics and for new knowledge and new approaches to tackle health-related misinformation and disinformation. And this panel, I think, will be a really interesting addition to the global discourse on this topic. We were hoping to have a colleague from WHO with us. Unfortunately, he had a personal tragedy and couldn't attend. But we do remember him today, Robert Martin. Virginia, one of our colleagues, has extensive experience in the UN, so she brings that connect with the global sphere as well. We'll find other ways of communicating and engaging with the global policymakers. We, of course, have national policymakers with us today. And the Vietnam context, I think, is an excellent opportunity to have a deep dive into this issue. So we will have, Nora's already introduced the speakers, but I'd like to say a little bit more about them before we actually launch into their perspectives. Dr. Nguyen Thanh Puong is director of HSPI, the Health Strategy and Policy Institute, which is part of the Ministry of Health in Vietnam, and project co-PI of the UCL HSPI collaborative project on HRMD. Dr. Puong is a leading public health expert and health economist with an expert in health financing, health economics, and health systems reform in Vietnam. Professor Virginia Murray is Honorary Professor, Department of Risk and Disaster Reduction at UCL and Head of Global Disaster Risk Reduction at the UK HSA, the Health Security Agency. And Professor Murray has been editor of WHO's guidance on research methods for health emergency and disaster risk management, including WHO's special program to address false or misleading information in digital and physical environments during the pandemic. Dr. Yushi Zhang, my colleague, is an assistant professor in health policy and systems at the UCL Global Business School for Health, and she's principal investigator of the UCL HSPI collaborative project on HRMD in Vietnam. Dr. Stephen Roberts is a lecturer in global health at the UCL Institute for Global Health, our sister department in the faculty, and co-investigator of the UCL HSPI collaborative project. And we're missing Dr. Robert Martin, as I mentioned today. But let me pass on now to some reflections from the panelists, and then we'll move on to an open discussion. So to start with, I'd like to invite Dr. Puong to say a little bit about the Vietnamese context and how do you feel HRMD, health-related misinformation and disinformation, has influenced health service use both during and after the COVID pandemic.
Thank you, the moderator, and thank you all for being today with the panel discussion about this topic. In Vietnam, like any health system, the primary function of health system is to adapt to meet the healthcare needs of the people. And the country now is facing with the increasing demand for healthcare. We are the developing country with the relatively fairly high economic growth rate. We maintain about 6% of the growth in economic, so it leads to the increase in the living standard for the people. And when the income increased together with the education and literacy increase, so also the awareness of the health and the healthcare needs also increased. And also in Vietnam, we are now under the transitional epidemiology. So at the same time, the health system faced with the triple burden of disease. We have the very high burden of NCD, which now account for the 77% of the burden of disease, and more than 80% of the mortality caused by the NCD. So and also the Vietnam is among the country with the fattest aging population. Currently, we have about 14% of the population is over 60 years old, and about and also the 9%, more than 9% of people more than 65. And very soon, about in the 20 years, the Vietnam will become the eighth population. Now we are at the gold age of the population, but we become the 8th population not far from now. And also we now at the very fast of the development of technology. So there's emerging of the new medicine, new technology, and the many device with the AI and the new technique come. So that associated with the high cost of on the healthcare is increased. So in that context of the increasing the healthcare need, so that also the increasing and the widespread of the health-related misinformation and disinformation. So this HRMD impact on there's the lastly significant impact on the health service utilization, and this can be seen very clearly during and after COVID-19. So firstly, we can see there's because of the information on the spread of the information on the adverse effect of vaccination. So there is lastly the reluctant hesitancy on the vaccination. So if this lead to the drop of the vaccination coverage, Vietnam has been proud of the national vaccination program for more than 30 years, with the high coverage, more than 90% of the vaccination coverage. And it resulted in the many fantastic result in the eradication of the many diseases, like the measles and the smallpox disease. But then we can see recently, because of the drop in the vaccination coverage, is there some the relapse of the preventable disease, like measles. There's increasing the cases of measles has been reported recently. So that we can see that the very obvious consequences of the HRMT. Secondly, there's also is that because of the misinformation on the false treatment treatment of the former treatment. So the people turn into the belief on some like the refuse the formal treatment and turn into like informal treatment, and with not based on any scientific basis, and people also tend to use the instead of the going to the health facility, healthcare provider, but the people tend to like the increase self-medication and buying the like the supplement food. Supplement food are the even spiritual therapy on belief of some the people that they trust on the have the basic cure of the disease, especially for some like the cancer disease, when the patient very in the very miserable condition and little hope to the cure to improve their condition. So all of this turn into the like the burden of the public health system, and also the higher the cost burden on the people spending on the many things that's do not bring the good or the evidence outcome, health outcome. And then also another type of the consequences that in Vietnam we have the last network of the grassroots healthcare. From the district to the commune level. We have the more than 10,000 commune health stations which provide like the primary healthcare for the people at the bottom level of the healthcare system. But there's also the rumor that the district, commune, and even district health center or hospital cannot treat even the diabetes. So the people that tend to the bypass the lower level, commune and district level, they go straight to the higher level, like the province and the national level hospital, created like the overcrowded at the higher hospital, and then also even they turn to the many private practitioner associated with the higher cost, especially even indirect cost for the people because of those the bypassing the lower healthcare level provider. In the disadvantaged area, like the mountainous or in the ethnic minority group, when the more difficult to access the healthcare the healthcare provider, and also the vulnerable into the misinformation and disinformation, so they are even more attractive by the word of mouth or the short video like the TikTok or the reels in the Facebook, and then or advice from the acquaintance or friend or the relative. So that channel is like the very like the social persuasive, but very it often inaccurate and knows verify or the scientific basis. So all of these consequences cause to the burden of health system, more the costly health system and for people, and we see that very clearly recently become the more the critical for the health system to face with. Yeah.
Thank you so much, Dr. Pong. That was quite a reflective summary of the different types of impacts on health services. And to be honest, I don't feel that is very different from what is happening in other parts of the world. We see that happening here in the UK as well. And there are, I think, some also broader trends that you reflected on around self-care and self-medication, the role of digital. And so I think it's very interesting to see this in that perspective in terms of the broader shifts that are taking place in the relationship between health services and the population. And also you reflected on the private sector, which is, I think, something worth thinking about, and whether there's a movement of clientele more towards a different range of health services. So with that, I think it's a good time to move on to some of the actual findings of the study and reflect on those a bit more. And I'll ask the PI and the co-PI to reflect on that. Maybe starting with Yushi, what insights emerged from your project? What do you think about how HRMD affects patients, and maybe you're going to emphasize NCDs, right? So over to you.
Thank you, Kabir, and really appreciate the opportunity to share my research findings. So firstly, I think Dr. Fong has given some insights from health system perspective. What really surprised us from this research, I would share two points, and then my good colleague, Dr. Stephen, can share more. So firstly, health-related misinformation and disinformation is a working concept. It doesn't capture the complexity of the issue, and we are working hard on the taxonomy and typology of the issue. So normally, generally, we believe health-related misinformation would normally be used when the motivation for spreading the information may be unintentional or not necessarily very vicious. Whereas disinformation is normally associated with intentional harming or discreditability of vaccine services. So it's a direct attack on the health system. However, at the same time, in our policy reality and how people understand it, we also find other, interchangeable concepts such as rumor and unverified information. So so on the research side, it really tells us, it's a very undefined area. I will give you an example. There is when we were doing our research in Vietnam, one case come up to our attention, which is it's one of the ingredients or enzyme in grapefruit. It's about the scientific research of the the ingredients of grapefruit that can have interaction with drugs. That is actually a scientific information. And that got misinterpreted, not necessarily for any harming purposes. It's probably just want to warn their family member, try not to take grapefruit when you take certain medication. But then with the word of the mouth, what Dr. Feng mentioned, it quickly get misinterpreted and actually become a widespread information that the grapefruits or even the pomelo in Vietnam can have health harming effects, and it's actually quite a blow to the fruit, farmers and industry. So as you can see, there is so funny because scientific information move to misinformation and get used by people intentionally become disinformation. So they are not absolutely not clear cut. They can move, transform from one category to another category. What does it mean? It means we need to view the issue and manage it with a complex systemic approach. So it's not a, traffic light system where you can, categorize them as red, yellow, green, and then follow protocol. So you really have to understand information ecosystem as quite messy and complex, and then manage it accordingly. Second, quickly, the viewpoint is I want to talk about patients, population, or information recipient. Unlike we normally, when we need to revolutionize how we think about, health, information, education, and communication programs, and how we think about people as little nodes online and where information just pass through them. They are not passive recipients of information. They are, like in a way, consumers of information who got educated by the social media age. So they are actively seek out for information, and they are not satisfied with information that passed on to them from top down. They need responsive mode in our health communication. For instance, we find that cancer patients are quite susceptible to HRMD, health-related misinformation and disinformation, not because the IEC program, the official information, education, and communication program being not enough. It's not the absolute lack of information that's a matter. It's because they actually have relatively good connection with doctors and they can get scientific advice. It's their unmet need for information on the forefront of medical technology. They want to know what is coming in the pipeline. And that is something our doctors and health professionals are not trained. They might need some media training, right? They're not trained and not very comfortable to, kind of forecast or say something. It's about accountability. What if they say something, what is going to happen, but also their skills. So they need capacity building training, but at the same time, it's definitely misunderstanding that these patients, they are passive recipients. No, they are actually, they do TikTok, they talk to ChatGPT, they are actively seeking out for information. And, we can come back to this later, but that gives a really good backdrop for introducing more responsive-based mode or even AI-powered solution to the issue. Yeah, I'll stop here.
Thank you, Yushi. That's so interesting because when we teach health systems and health economics, one of the things we talk about is information asymmetry and why the health market is different from other markets. And in many ways, the digital age is actually helping us overcome the asymmetries by making information more accessible to everybody. But then, as you said, there's an overlay between information, misinformation, disinformation, and it all becomes part of a information ecosystem that we need to study in its entirety as a complex system. So thank you for that insight. Stephen, what surprised you most about your findings? Do you want to say a bit more maybe about your experience, but also a little bit more about what was surprising about the findings and what was unique?
Thank you, Kabir, and thank you, Yushi, and thank you, Dr. Fong, for your reflections so far. So I'm a qualitative social science researcher, so I'm always interested on what is happening in communities and what's happening on the ground, what people are saying. there's been many things that have surprised me so far with our findings. I think, first of all, it's where this might be discussed as a problem or identified as a problem. So we can talk about HRMD in policy circles, we can talk about it in academic circles, research circles as well. In every interview we've done, every focus group, World Cafe session that we had with the team, there's widespread understanding that this is an issue. This, particularly among members of community and lay people as well, particularly the patients we spoke to. As Yushi said, it might be conceptualized and discussed in different ways. The definitional clarity of what it is might vary. But everybody we spoke to, really ranging from patients to health experts, members of different institutions across Vietnamese government, Ministry of Health, there's a very widespread understanding, really from top down, that this is a huge issue, right? And I think this provides a really fascinating time to act and to intervene and to work collaboratively. I think the second thing, I usually try to think in threes with these type of responses as well. I think the second thing really is, we often talk about this perhaps on quite a theoretical level, but we have really seen it playing out in the Vietnamese context of the limits of siloed thinking, right? Conceptual thinking, definitional thinking. Yushi has spoken in really great detail to this around the variance of terms when we talk about HRMD, fake news, infodemics, misinformation, etc. I reflect a little bit farther on this divide that's long been there when we think about fake information, misinformation, and really being the traditional remit of communicable diseases, right? And we've spoken about this for many reasons: securitization, the fear of outbreaks, the fear of pandemics, the ability for false information, misinformation to spread very quickly during public health emergencies. But as we now see, the greater challenge and the impact to healthcare systems, as Dr. Fong was saying, really is from non-communicable diseases. And we're seeing this challenge play out, perhaps in part as this kind of gap that we've traditionally had in the separation between the challenges of communicable diseases on one hand, and not thinking more synergistically between the two and the common challenges. And then I think probably the third aspect, which Yushi had spoken a little bit about regarding the cancer patients we've been speaking with and kind of engaging with as well, is that there is a health systems impact, and there's a physical well-being impact to all of this as well. But a lesser yet emerging challenge around mental health and well-being amongst patients that are exposed to HRMD. We can talk, for example, in terms of vulnerability. So a lot of these individuals are quite ill. They're navigating, I think what the term has come up, hope and despair, in looking for different treatment options, different things that might improve their quality of life as well. And so this is something I think we need to be really, really aware of, attentive to, and sensitive to, is that there's a very human aspect to this. There's a health systems focus as well. But also there is this element that is highly vulnerable and highly emotive when we're working with these communities that are navigating their very complex health and well-being statuses.
Thanks so much, Stephen. I think this reflects on how information is never just information. It's information in context, and that context is what people experience in their day-to-day lives, and often that comes with deep vulnerabilities, and different types of information can spark different responses. I think that again speaks to Yushi's point about it being a co-production, seeing people as part of the solution, and not as passive recipients of knowledge. So maybe a good segue to now start thinking a little bit about what we can do about it, and what the world can do about this problem. I think it's a problem, but it's also a phenomenon which has many different components. So we have an expert with us who's worked extensively on this topic in the context of disaster and emergency communication. Virginia, would you like to draw on some of your experiences and specifically together with us about institutional capacities and interventions? I think you have some thoughts on that.
Thank you so much. What a privilege to be here with you all. What an opportunity to hear you, Dr. Fong. The story you tell of what's happening in Vietnam is so concerning, but it's something we've heard around the world. Lovely to hear about the work, Yuchi and Stephen, that you are doing at the moment. absolutely key that you're coming together with it. So I thought I would start, to me, at an area where we have global agreement. Let's go for something global. So I had the great privilege of being the vice chair of the Science and Technical Advisory Group to support the development of the Sendai Framework for Disaster Risk Reduction. The Sendai Framework is one of the 3 UN landmark agreements of 2015. It's an incredible framework where all the UN member states came together, all 193. We worked really hard on it, and I was supporting from the science and technology side with trying to get it absolutely clear. So I'm going to quote one paragraph from the Sendai Framework. It says, to promote national strategies to strengthen public education and awareness in disaster risk reduction, including disaster risk information and knowledge, through campaigns, social media, community mobilization, taking into account specific audiences and their needs. So the health audience you described, Dr. Fong, is written into what has been agreed globally. We did this in 2015 after much discussion and negotiation. But of course, with COVID, disinformation hurt. And we all got frightened in every country in the world. So our wonderful Secretary General of the United Nations, Antonio Guterres, called for a special report on countering disinformation for the promotion and protection of human rights and fundamental freedoms. Isn't that great he did it? Isn't it what you need, Dr. Fong? He's noted that countering the different manifestations of disinformation requires addressing underlying societal tensions, fostering respect for human rights, online and offline, and supporting a plural civic space and media landscape. What you're talking about has been addressed at the United Nations, both in building a UN landmark agreement, but also in agreeing what we have to do to support misinformation. So one of the projects that I have been leading on as the chair of the technical working group is something that may be helpful to you. So I have been working with UNESCO and the Committee on Data for the International Science Council, where I'm a fellow, on data policies in times of crisis facilitated by open science to build trust, principles, values, to make sure that we can build this so that each country can take forward that understanding of why we need to do it in a fact sheet, which I brought with me if you want to have a look at it, but also guidance on how to do it, and a checklist that tells you what you need to cover for human rights, for fair, findable, accessible, interoperable, reusable data, trust data, care data for the indigenous communities. All these things are key. So we have at the UN level wonderful tools that I hope Dr. Fong will really help you in implementing the changes we need to make at a really high level. The final thing I brought for you is that we need standards. And the one thing that we've published, because I've been the chair of the UN Office of Disaster Risk Reduction and International Science Council steering group, working across 40 different UN agencies, many science organizations and unions, business sector, and my wonderful friends from communities. So we've used the International Federation of the Red Cross, Red Crescent to help us to deliver the global list of hazards. So you have definitions that are trusted and agreed and adopted by our UN partners, and very much part of the work they do, including the hazard drivers, the hazard impacts, the multi-hazard context, the monitoring, and how you manage them with risk management. And of course, vaccination is one of my favorite friends, as it is for all public health people. I want to share these with you to try and make sure that in Vietnam, these systems might help you. And if I can support you in delivering some of this at the high level, then I could perhaps follow with some community ideas that might be helpful.
Thank you so much, Virginia, for telling us about the work that's been done at the international level. And I think we're seeing and you also mentioned trust. And we're seeing major erosion of trust in the international organizations worldwide. So I actually wonder how, we should find ourselves, a way of acting in this new global environment as well. I think there's a trust. I mean, I think we've recognized trust as one of the most significant determinants of health systems performance. And information and misinformation is such a classical example of where there is trust, but the trust doesn't seem to be where many of us in the scientific community want it to be. It's the trust lies with the more kind of emotive messages that people are receiving, with not in the kind of centers of authority that we're used to seeing them, as we in the scientific community are used to seeing them. So it's a really complicated question about shifting that locus of trust. Would you like to say a bit more about it? But then I'd also like to open it up to the audience and have their views as well.
Of course, I think you're absolutely right. We must ask what the audience feels, because this is a partnership. But I really wanted to share with you that the Royal Society of the United Kingdom have been working on trust. And we've done a lot of work with stakeholders, with frontline engagement, looking at how trust works, particularly in times of crisis. So we know that we must work in partnership with people. We know we have to listen to people, hear them, really hear them. So we need to involve with local communication networks. We know we need to empower local leaders. We know we need digital and media literacy. Health literacy is critical, as WHO says. But we also need community-based training so people understand their personal risk for misinformation and disinformation. What does that mean for them, their family, their friends, their colleagues? And the European Union has just brought out last week a wonderful shopping list of 10 points of how to protect yourself from disinformation. To me, there are so many resources out there that we should implement locally. And science is going to be a group that I think we should really offer to work with you in trying to take this forward. I hope, Dr. Fong, this will help in Vietnam. But what you're doing to lead is something that we could contribute and share globally. It's so exciting. And thank you for your engagement with UCL and this wonderful research program.
So I think the other lesson here is that it's really heartening to hear that it's a UN-wide initiative, and that really points to the importance of a cross-sectoral approach to an issue such as this. It's not just a health-related issue. It's a cross-sectoral issue, and beyond that, it's a societal issue. So maybe on that note, we can invite questions. I'm sure there's some questions online as well. Nora, why don't you kick us off?
So I just want to follow up on Professor Murray's comment, because I think it's a really important comment, and that is, how do we? Of course, we have all these tools we have, but why aren't we seeing them engaged better by governments and state? And why are we not embedding it better into our education systems so that we can really address this, right? Because we're not going to be able to control social media. And we know that these algorithms are creating all sorts of bubbles. So to me, it seems that, the most, as a, not an expert in this area, but the education system is integral then to this, but I don't see it happening. Or is it happening and it's just not widespread?
Thank you, Nora. So let's take another question and then we can see if the panel would like to respond. Are there any more questions from the audience? There's a question back there, Sarah. Front row. Front row. Yeah.
Good afternoon, everyone. I am Abdul, a student in the Department for Global Health. Global Health and Development, to be specific, and also a clinician from Sierra Leone. Thank you very much for all the amazing work that you've been doing. My question is in relation to misinformation that is directly related to political alliance. For example, back home in the 2014 Ebola outbreak in West Africa, political alliance played a major role with regards to misinformation, especially in the part of Sierra Leone where the outbreak started. It was back then the opposition stronghold, which led to lots of misinformation. I want to know if there are any policies at the top level within the top organizations that have clear directives on how to handle these complex misinformation, especially in sub-Saharan Africa.
Thank you for that question. Maybe we can take one more because I think there's quite a different range of different themes coming up. Sarah, is there anything online that we can add?
I might add this one online, which is a bit aligned with the last question that was shared, which first from Jessica, she says, thank you for the insightful discussion. Often disinformation is spread to further a specific political or social belief. And actually, she would like some clarification from Yushi on the grapefruit pomelo example you gave. What was maybe the motivation for people deliberately spreading disinformation in that case?
Great. So we have two very distinct threads. One is, are we looking at the education sector, and are we really operating in bubbles, which we need to look beyond? Are we all just speaking to each other, or are we actually engaging with communities? Did I get that right, Laura? And the other is on political determinants and policy responses. And we have actually graced by a policymaker today, and he will give his responses as well. So we might ask Honorable Levan Khan to respond to that, but also other panelists as well. Why don't you kick us off, Honorable Khan?
Distinguished Professor Nora Kundan, Professor Tabi Sheikh, panelists, professors, and students. I would like to reflect on the challenges of how related information and disinformation had RMD and its implication for policy in Vietnam in the coming time. Based on the recent analysis on this issue during the COVID-19 pandemic and vaccine hesitancy, as well as finding from the HFPI and UCL joint research on NCDs, it is clear that HRMD, with its multidimensional and urgent nature, reflects not merely a limitation of communication, but a systemic issue that intersects with trust, governance, and the very architecture of our health system. First, HRMD undermines public health by spreading false health about disease and treatment, by eroding trust in health institutions, distorting perception of nature and services quality, and influencing patient behavior in ways that strain both public and private systems. In Vietnam, for example, misinformation and disinformation about cancer treatment or quality of public healthcare service at grassroots level led to patients to delay their treatment while encouraging them to increase the use of unregulated services. This has resulted in health consequences, economic burden, and other social impacts. As our panel highlights, governance of HRMD must move beyond reactive messaging to address deeper accountability gaps on the multi-sector responsibility and emotional vulnerability in the patient and health system relationship. This calls for a shift from top-down information campaigns to co-designed trust-based communication strategies that are responsive to pace-lived reality. Second, there is a pressing need for further evidence-based research to inform policy. I believe that the recent collaborative research between UCL and HFPI in Vietnam has demonstrated the value of participatory methods with policymakers, clinicians, and patients to uncover how misinformation circulates in everyday contexts. The mechanism by which stakeholders recognize and address misinformation and disinformation in digital space and community settings. These findings underscore the importance of investing in qualitative and system-based research that captures the complexity of HRMD, serving as a foundation for proposing context-sensitive and goal-oriented intervention. Without such evidence, policy response risks being overly technocratic and disconnected from the realities on the ground. In addition, in the near future, further research is needed to quantify the scale of the issues, especially in relation to unexplored aspects of NCDs, which account for a larger proportion of the disease burden in many countries. This will serve as a basis for advocating policy that require commitment and participation from multiple stakeholders. Quantifying HRMD scale and the health, economic, and social impacts of HRMD will provide a foundation for policy advocacy and for mobilizing resources, commitment, and the engagement of multiple stakeholders. Finally, I am aware that Vietnam is entering a critical phase with a new vision regarded as a policy window. The COVID-19 pandemic has heightened the awareness of the dangers of misinformation, and the government has already taken steps through legal measures, public education, and partnership with technology platforms to counter its spread. However, this momentum must be sustained and expanded to other health conditions, such as including NCDs. The current period offers a unique opportunity to institutionalize stronger policy on health. Integrate HMG rallies resilience into IEC programs, establish an official information system, provide knowledge, and build the capacity of healthcare workers and the public to access and process information. The guiding principle is that controlling and arresting misinformation is not merely about correcting the facts, but about empowering communities, strengthening the system, and ensuring equity. In sum up, to effectively arrest HRMD in each country, such as Vietnam and globally, I agree that we need a whole of system approach with evidence-based and context-specific, shifting from reactive measure to proactive, inclusive, and sustainable solutions. Thank you very much. Yeah.
Thank you, sir. Thank you. That was really insightful. You mentioned that fact-checking doesn't always work. And I think that really supports the perspective that misinformation comes from a place of belief, not from a place of wrong, and just you can't just correct the information that's out there. So a lot of things have been raised. I think it would be good to reflect on the issue of the engaging the education sector, maybe, and also on policy and political responses. Would the panelists have any views on those points?
Yeah. Well, maybe I take the question on the concerning with the policy, the framework to address the HIMD issue. Since from the fact in one of the critical challenges and difficulty in the country to respond with the HIMD is we lack of the strong and dedicated legal framework to address the HIMD. Now we have the issue of the HIMD have been addressed in the severance law, but it seems that the very fragmented and also not strong enough to address the severity and also the harmful impact of the HIMD on the people, especially on the health, the people health. And the second issue is about the coordination, because we need the jointly effort from the different stakeholders, different ministry, from the central to local level. So we need to have very strong and effective coordination, which is regulated by the legal framework. So we need to have like clearly define the role, responsibility, accountability of each stakeholder concerning with the responding, prevention, protect people from the HIMD, as well as the effective measure to respond to HIMD when it happens. And thirdly, is that we need to, like the panelists and also Mr. Kham mentioned that to address the HIMD, it's not just a technical measure, but we need to have like a system approach, a system measure to tackle with the issue, and also we need the resources, more resources to action, to work on that. Now in Vietnam, the resources shortage not only in terms of the money of the funding, but also in terms of the capacity of the manpower, not lack of the knowledge, skill, and also there's no, we do not have the full-time worker to work on this area. Yeah, so based on that, I think that now in a country like Vietnam, when we need urgent action to address the HIMD, so we should start with to develop the dedicated legal framework with provide the inclusive and systematic measure solution to address the HIMD from the identification, detection of the HIMD, and then the effective measure to respond to HIMD to protect the people from the HIMD when we have the more effective channel to provide the scientific, timely, and accessible information to the people. So there's no place for the fake news or the disinformation or misinformation for the people. And then we also need to have the maybe stronger stronger and the more severity penalty to the violator, because now in the law there we have some like the administrative penalty, but it's now it's in the very compatible lower than the economic gain from the violation of the law. And now we propose that in the law we should have the stronger the regulator and the penalty, yeah, for the violator. So Virginia, you have something to it?
I love to try and support you. I think you're right. But to me, it's a whole of society, but it's also a whole of government issue. It's not just health. Health is the tip of the iceberg of mis and disinformation. But you mentioned financial issues. Everything is about information, credibility. And disinformation and misinformation is so dangerous. I'm fascinated that in the educational messages that the European Commission put out, it says, stay vigilant, learn to decode information, particularly disinformation, verify the source, fact-check, cross-check information, think twice, investigate, educate yourself, encourage critical thinking, and report suspicious content. Is that not what every scientist should be doing all the time? Is this not what science education is about? Education at every level? But is this not what a whole of government approach should be? I think we should all be working together to deliver this. And then we might support some of the NCD crises you're facing, which I think are truly frightening. But what a wonderful panel discussion. Thank you for the privilege for allowing me to join.
Virginia, could I ask a follow-up question to that, though? Why should Vietnam listen to the European Commission? What is the authority of the European Commission?
Because it's a regional approach, and maybe we need a regional approach in Asia. We need a regional approach, certainly in South America, but whether we need it in North America, I'm not certain at the moment.
Yeah.
But let's
I'm
leave
just
that
concerned with the discussions currently around decolonization and the role that international organizations and higher centers of knowledge such as UCL have. And, you know, here, I mean, I've seen the way that Yushi and Stephen have worked, and they work very much as supportive partners to the local partners. And we do try to emphasize that approach. But is there a reflection there maybe on where the thinking should really be coming from?
I think to me that the fact there have been so much thinking about this, not only in the World Health Organization, but across many of the other UN agencies and other organizations from the World Economic Forum and others, this is critical. What we don't have in our hazard information profiles, to go back to them, is a hazard on dis and misinformation. But what we do know is that it is a driver of hazards. Just as climate change is a driver of hazards, as AI can be a driver of hazards. But what we do have are things like cyberbullying. And is it not a lot of this misinformation and disinformation associated with cyberbullying? Is it not worth reporting some of this so that we can measure the impact in human health, loss and damage that we can do something about? Yeah. That is the global call. And if we share that data, maybe we can make a stronger difference together. Wouldn't that be exciting? Thank you.
Thank you. And Dr. Phuong, I was really struck by your comment on a punitive measure and a regulatory approach. And it's actually true that health misinformation and disinformation costs lives. It has very significant and serious consequences. So it would be really good to actually have a little think about the regulatory perspective as well. And I know different countries would have different perspectives on that, but how do we actually identify the perpetrators, the people who are actually spreading this misinformation? So maybe some thoughts, some reflections on that from the panel would be great, even from the audience. You have a question or a response to that?
Hi, my name is Yafachi Douglas. I'm a public health student at the University of East London. So on what you said, actually was basically, there's the idea that obviously the monetization, I guess, of health in terms of like making financial profit from health is causing people to not believe what healthcare scientists and professionals are bringing forward to the general audience. And would you say that that is like probably influences this, or like if it's also probably an issue that we also need to tackle as well in terms of building trust with people and ensuring them that we're not just giving them certain medications or care to make them even sicker so that they can then come back for more healthcare? Would you say that that affects this in any way?
Okay, thank you. Okay, so many questions to respond to. She, would you like to take?
Yeah, I can start with addressing some of the questions. I think I can actually combine two audience from the front row. Your question is related to the multi-sectoral determinants of the issue, but also I will address the specific question online for me. So to start with, I think it's fantastic because collectively, really, right, we are co-creating knowledge. We identified there's more than one kind of determinants or one kind of motivation for, you know, creating, spreading, or believing HRMD, the misinformation, disinformation. Commercial determinants or commercial interests is definitely identified as one of the main interests, especially in the online marketplace. But there is a nuance behind that commercial determinants. It's not always, you know, it can be very legitimate motivations. People might be leaning towards the longevity and wellness, you know, industry. They're trying to, a lot of the time, that's why NCD-related HRMD is quite interesting alongside communicable diseases, because these HRMDs, in its nature, it's less, you know, sort of direct attack on science. It's normally trying to sidetrack people by mask those HRMD under the very legitimate pursuit of, you know, I can even enhance doctors' protocols. You know, hopefully by having you know, these treatments, they normally brand, we are going to boost what the doctor tells you. So yeah, you see that under the the commercial determinants of this HRMD. So what it tells us, it's a multi-sectoral governance framework. And really, you know, we talk about the cross-country, but again, you know, cross-sectoral, and also, you know, sort of, you know, if you think about it globally, it's not intergovernment, but as a, you know, we talk about the commercial determinants often, you know, more often than not, there are very legitimate reason behind the wellness and longevity industry. They're trying to, you know, support people. So there is this ethics, there is this management, and this value-based, you know, governance framework of HRMD. But of course, political determinants is also, you know, behind HRMD. I think, you know, those political determinants, you can see they normally come in waves. Yeah, so a lot of the time, if there is a health emergency or, you know, a vaccine related HRMD, you can normally find political drives behind. But then again, you have to think about, you know, commercial determinants, political determinants, social determinants, and, you know, sometimes the value and ethics determinants. So it should be a cross-sectoral and systemic level solution. And just quickly addressing the online question directed to me about clarifying the drives behind the HRMD related to grapefruits. It can be multiple. I think where the whole reason, the whole panel here is we're trying to redefine the paradigm behind thinking about HRMD. If you're really trying to do the lineage, you know, linear process tracing way of tracing all the origin and the motivation behind every single HRMD online, health system are gonna get overwhelmed. Community health workers got you know, exhausted, and it's basically not possible with social media. There are many reasons behind the grapefruit. As firstly, it does have a scientific ground, but it's in a very strict laboratory environment, and it's talking about the interaction with drug ingredients. So but then it go oversimplified and get, why people spread it. It can be intentionally try to harm the farmers, but it can be just, not harm at all. They're just trying to warn their family member, watch out. You probably don't eat, don't eat 2 grapefruits per day, maybe just half. So I would say, yeah, so that's, so to summarize, I think what we are advocating for is multi-sectoral governance framework approach to HRMD management, and revolutionize the research and understanding of it. It's not a lineage. It's not going to be tracing it, but more from the human-centered, what people believe and what people trust. I'll stop here.
I think,
Thank you so much, Yushi. Stephen?
yes, I think you should just add to that really kind of excellent point of state of play of where we in the project right now as well, is that with all of that as well, none of that can be accomplished without a participatory approach. And so this is what we've been doing. I teach qualitative methods, I lecture qualitative methods as well, and we've been having these discussions for quite some time with the team about the way to pull and center lived experience, local expertise, and local knowledge. Because as Yushi said, with all of these complex issues, identities, and interests playing into one another, it's impossible to understand that, right? If we only take one particular approach, for example, focusing on a commercial determinants approach only, or even methodologically, like we've said, there's been a lot of work done on this on social media analysis, right? We need to go farther. We need to work with communities. We need to work with informants at all levels of society and government, right? And only then, I think, there was a really wonderful quote that came from one of our scripts so far. How it was translated, I'm not sure, but in the Vietnamese context, it said you need to work hard to clear the field so the rice can grow better. And I just think that's so fitting for our discussions today of the work that we've done, but all of the work that needs to be done, community level, government level, healthcare systems level, in thinking about collaborative action on this issue to make things better.
Wonderful. Thank you so much. Sir, please.
It is a very technical issue in relation to misinformation, health misinformation. I have a comment and give a question to Professor Virginia. Yeah. I think that we have a lot of experiences to deal with the HRMD in infectious disease, even in epidemic. But in NCD, we have don't have much experience on that. For me, I think there's a difference between the infectious disease with non-communicable disease in terms of how this disease happened, and for the people who are coping with the chronic disease, they have their own experiences, and they want to share with others their own experiences. For the infectious disease, when the infectious disease happened, all of the people in the community act together to cope with the disease. But for the chronic disease, the people suffering by themselves, and that's a disease for their own disease. So, I mean that there's a difference between at the individual level and community level to deal with the infectious disease and communicable disease. So I would like to ask the Professor Virginia that what is major difference between the way we deal with misinformation among infectious disease and non-communicable disease, and what we should pay attention on that? Thank you.
What an amazing question and a great honor to reply to you, sir. Thank you. I don't think I know you're focusing particularly on non-communicable disease at the moment. A huge issue and such an important issue when we know from Dr. Fong that it is your major concern from the health point of view. But I think there have been people who have confused communities for years. We've had counterfeit medicines and many other things that have gone on for many years. It's not a new phenomenon. And in our hazard list, counterfeit medicines make the cut, they're included. So I think there's things that might be important to discuss further. And I think how you separate out non-communicable diseases from all the other emergencies are quite difficult to work through. But what we do seem to feel, having worked at the UN level, looking at the global issues, misinformation and disinformation, as Antonio Guterres, as the UN Secretary General has said, is not just an NCD problem. It is much more a problem of the whole of society and the whole of communities. And having worked with the International Telecommunications Union, who deal in cybersecurity and are the cybersecurity leaders for the UN, they are truly worried about how many problems occur with misinformation and disinformation and scams all over the place. They report that many millions of dollars are lost every single minute, hour, and even more every day. The confusion that people are in is really frightening, but we need to try and develop stronger systems for the whole of government to support the whole of society. And that would be a really exciting challenge for the future, to see this project to help to be a stepping stone for what we might be able to achieve more widely. Thank you for including me in this conversation.
Thank you, Virginia. Yoshi, would you like to add something?
Yeah, just quickly, I think this is a fantastic discussion, what's so specific about NCD as compared to communicable diseases, and what can we bridge, like think them all more holistically. So by highlighting NCD, this project is not trying to reinforce the vertical, paradigm of thinking about disease-specific, approach to health policy or, global health. Rather, we are trying to highlight that not enough attention has been paid to, NCD as a content, the HRMD, and why is that, or why does that matter? Firstly, as I said, NCD is normally not try to persuade people to disbelieve science. It's try to overwhelm people. And why that's a problem? Because social media analysis is keywords algorithm driven. You will need those attacking words to identify them and to distill those posts and conduct the analysis, or even tracing, when you use some AI tool to trace and monitor the issue. NCD related content is so much more nuanced and so much more complicated. So if you only use that, keywords or sometimes sentiment load, sentimental analysis, yes, that's going to be helpful in communicable disease and COVID. But with NCD, sometimes it's just, if it's grapefruit, what sentiment in there? There's no sentiment. It's completely neutral, and there's no keywords for you to grab it. So it's not going to pop online. It's not going to emerge in our social media analysis driven research. So that's why we kind of highlight the importance of NCD related HRMD. Yes.
Thank you, Yoshi. And it also makes me think about who are the perpetrators of some of this misinformation, and it's some of the biggest influence. I mean, it's literally influencers, isn't it? We now have social media, people who are very influential on social media, and they perpetuate these messages. And of course, there is an economy behind them as well that helps to perpetuate them. So it would be useful to think a little bit, reflect a little bit on that as well. But I was also wondering about this issue around the role of the government in all of this. We really see it as a societal phenomenon, and government is always playing catch up right? And your suggestion that maybe there should be stronger regulations on the perpetrators was a very interesting one. But I wonder also if there are different mechanisms we have which are non-governmental or which relate to the private sector and relate to industry in terms of how we can influence this issue a little bit more strongly. And of course, again, a reflection for the panel, but also for the audience.
How are you going to think about AI? Because AI generate more content and information. It doesn't necessarily always require human intervention. And as we know, AI hallucinates. And I was fascinated. Oh, I'm sorry.
Because we're recording.
Yeah, so I think AI is a really important topic that we need to bring into this conversation, because lots of the content today is generated using AI. And as we know, Chat GDP and other tools, they do hallucinate and they give false information. I was fascinated recently to read somewhere that many people now go to these chat boxes essentially to ask about medical conditions. And so it's no longer just Dr. Google, it's Dr. AI. So where does that sit in your thinking? Because that's a much, for me personally, I see that as a much more dangerous and worrisome development than necessarily just of course social media, but the way in which people are now accessing information and the trust that they're putting into AI. And at the same time, I say that we want to be using more AI in clinical settings. So it comes full circle back to this issue of trust.
Yeah. May I join to strongly echo with what the Nora suggestion, because I tell you a story from Vietnam. During the COVID-19 pandemic, Vietnam government has been also quoted like the highlight at the government have to effectively respond to the pandemic and can control well the pandemic, and the way the government to face and to address the HIV during the pandemic also is under the considered like the successful contribute to the successful control the pandemic. But by that time, when we talk with the one who had involved in that the government has to create like the multi-layer communication, the communication system to control the information from central to local level, and also to cover on the different channel of the communication and media. But by that time, there's no application of AI or the advanced tools, technical tool. So just there's group of people every day at the beginning of the day, they do like the screening of all the information in the like the web-based information, but not just the various the traditional the way with the group of people, and then they come up with a list of the information considered like the HRMD related to the pandemic, and then it transfer those issues to the authorized organization units and the person at the different ministry, including the Ministry of the Communication, Information and Communication, who control all the mass media and the journal or the radio or the television, and then Ministry of the Security, Ministry of the also Ministry of the Internal Affairs, and of course the Ministry of Health. So those in the on the measure, the solution taken in the very traditional way, with the in-person involved to respond to those HRMD issue. But now, when there's the booming of the IT and also the digital media, digital communication, we think that the way that mechanism cannot work in with the current situation. So with the AI, we think that we need to invest to create the AI integrated health information system. We can monitor any the information sensitive to the HIMD, and then we have the system to to get a system to address and recognize and classify, and then respond to those issues in the way very proactive and systematic. And we also can create the platform where the right good information, accurate, timely information, and we also personalize to meet the different healthcare needs of the people, especially for NCD. So with the AI application, we think that though can powerful not only the government but also the people to equip them to respond to protect them from HRMI, also to effectively to respond to this issue. So really to strongly to echo with what you suggest about the AI application. Yeah, thank you.
Please, there's a question there.
My name is Igor. I'm a student here, and my question is very simple student question. Could you please add to my knowledge the construct clarity of the concept of misinformation and disinformation in terms of, so I know that intention differs them between each other, but who decides what is wrong and what is right? Because if we look at this wall, white wall, it's a fact, but positivists will say that spectral is important, and constructivists will say that culture is important. And during the time, I observed the clinical recommendations, for example. In 6 years, European recommendation in cardiology changed twice one approach to opposite directions. So from the perspective of these people, one information will be right and wrong in 5 years. And another way, and another question is that for example, for conservative person who is skeptical, innovative things will be every time not enough evidence. And we can delay the development of society if we let someone decide in easy way what's right and what's wrong. So how we distinguish what is right and what is wrong in concept of medical information? Thank you.
Thank you. We're almost at time, so I'm going to take one more question if there is one, and then we'll ask for a summary from the investigators.
Hi, I just want to add to Mr. Sorry, I didn't capture it. Igor's question and ask a probably similar, a little bit deeper one. That is, we're talking about information. This concept has been, mentioning all the time, but we rarely mention about the concept of knowledge. So I wonder, and this is also closely linked to this question, what information is right, what information is wrong? But knowledge, for individual, we usually define it as justified true belief. That means knowledge has this trust in it that people would really act on it. So information is something kind of externally, whereas knowledge could be quite internally, developed. So I wonder, how the panel would see in the context of our topic today, how shall we, take the balance between information about health and also develop the knowledge for health or more particular NCD management. Hope I convey my meaning.
So it's such a fascinating subject because it opens up a range of practical questions for us, but also a range of philosophical questions for us, right? From the ontology and epistemology of the problems that we face. But I think we've just scratched the surface today. It's a really fascinating topic. I think there's a lot to think about, a lot to research. So I think we should put ourselves back in the hands of the investigators and ask them what they think, if they'd like to give a quick summary, but also think about what is the future of this field and what they would like to research. Maybe Stephen, a couple of minutes, 1 minute, and then usually you have the final word.
Yes, thank you, Kuru. And thank you everyone for just an incredibly rich and engaged discussion. I've really, really enjoyed thinking through some of these things and speaking with all of you today. So I think the thing that we've established is that we're at sort of the very beginning phase of our project. And there's many, many different directions that we want to go to. I think one thing that we are aiming to do next is moving the project into larger context within Vietnam. So what we've been doing so far is very much, we've been doing sort of our theory building, our data collection, but that really needs to be tested further in the context of a country where you have so much kind of enormous levels of regional cultural diversity as well. I think also in terms of just general areas of interest that I'm thinking further, I'm picking up again, Dr. Fong, on your discussions about AI, and I think Professor Nora, this question came from you as well, as about the state of play of AI and where are we going and how does this fit into our project, or perhaps a future area of research within the project. And I think what I'm interested in actually is that there's a lot of doomsday saying about AI, but AI is proving actually to advance quite quickly and be incredibly productive in many ways, including in things like health communication. And one thing that I'm really interested in thinking about, perhaps further in the context of this project at some point, really is thinking about productive or successful applications of AI when we talk about correcting or providing correct health information, reducing HRMD, but what inequities still exist as a result. So who has access to this information? What are the pathways? And then what do we do as researchers to still bridge those inequities essentially as well? I think those are probably my main takeaways so far, Yushi. So lots more to come. Thank you again. Yushi, happy to hand it over to you as well.
Okay, so it's really, really a privilege and a great opportunity to have this discussion. I think at the end of the day, we actually naturally come to, all of us co-create and come to the shared idea that we need to go beyond information or communication per se. It's about what is right or wrong of the information. It's about the power and politics in knowledge, who has authority. It's about the value and ethics of AI in healthcare, and how should people approach to AI in health? How do people evaluate this evidence? So the first, I think the shared takeaway would be we have to go beyond technical discussion of the question. It's not just a one-dimensional or one-directional pass down of facts from top central government to individuals. It's about these, rapidly changing, but waiting for definition or debates area. And it's about almost like the learning loop, the third learning loop. How do we get to know? It's a capacity building into the knowing. And then related to, I want to draw the conclusion to AI. We are actually, as a world's first business school for health, we are already discussing with quite a few colleagues here, including Suzanne, who is expert in AI, about the low-hanging fruit. Will be use AI to the system where the mis and disinformation regarding the health system, especially some misunderstanding of low capacity at the grassroots level primary care, can be controlled. That's actually the low-hanging fruit. And going forward, extrapolate from our health system beyond, I would say it's technology. And I really think colleagues here, we should continue the discussion and try to be the lead in the thoughts regarding the ethics and the value of AI in health.
I think that's the last word. I don't think I can top that. So thank you everybody for joining us today. And thank you for our distinguished panel. And thanks especially for people who joined online. I'm sorry the opportunities to engage were a little bit limited, but we did hear some of your questions. And I think there's some food and drinks outside. So please join us there and we can continue the discussion. Thank you.